Hi, Mohammed Al Mala here. I wanted to share this case as it was one of the more challenging capsulorrhexis cases that I've done over the last few months. Here see this patient has a mature cataract. We're putting in blue dye to stay in the anterior capsule, and we notice already that the capsule looks a little bit different. It's fibrotic in areas, and we can see that there's asymmetric attachments, or what looks like possibly asymmetric attachments to the underlying cataract. You can see there's some wrinkles or folds in the anterior capsule. A capsule like this is highly unlikely to have a cataract that's under tension. So I typically do not feel the need to go in here with a 25 gauge needle or some sort of needle initially to aspirate the cortical material. So with a capsule like this that looks fibrotic, we have to be really prepared for anything. So let's see how this case progresses. As you can see, I'm going in with the cystotome first, no needle. You can see the capsule here is pretty adherent. So I'm trying to make a cut in the anterior capsule and trying to raise a flap, but having really very limited success here. At any point in time, we can switch to a can opener, capsulorrhexis, where we make tiny incisions all the way around for 360 degrees. But here you can see I've kind of made an opening, and I'm trying to raise a flap here. And really not making some progress slowly here. Here we go. Possibly raising a flap here, but it's just so rubbery and difficult to work with. So here we go. We're getting a flap now. And I'm going to go in most likely with Utrata capsulorrhexis forceps. And let's see if we can extend this flap. But you can see that the flap that I raised just tears and is amputated. So we're going to take our time here. We're going to keep working slowly and see if we can raise another flap and complete a continuous curvilinear. Oh, it just amputated again. And we're going to try and create a continuous curvilinear capsulorrhexis. So we'll keep working. We'll slowly keep working at it, but the flap just keeps amputating. So we can tell that the capsule material is not completely the normal consistency that we're used to. Here we are going in, we're taking our time, we're putting in more viscoelastic. We have a small capsulotomy opening here. And as I said before, at any point in time, we can convert to a can opener capsulorrhexis. So still trying to raise the flap. And so let's try a different portion of this capsule here. Keep trying different areas. It's really important here just to be patient. Sometimes here we go. We're raising a flap now. And this is, of course, an unedited video of this surgery. Here we go. We're making some progress. We've finally gotten a flap that's not amputating, and we're able to create a larger, continuous curvilinear capsulorrhexis. So I'm going to take our time. I'm not going to get frustrated. It amputates again. And we can see that the eye is a little bit hypotenuse here. Maybe not be a bad idea to put in some more viscoelastic. But yeah, we keep trudging along. And now we've got a good size capsulorrhexis here forming. keep going. It looks like we're getting close to the home stretch and continuing this and finishing this capsulorrhexis. So I switch here. I feel that it's going to start running out, which it is, and so I turn it over and I start pulling towards the center here. And it is tearing in a curvilinear fashion, and we've completed the capsulorrhexis. So this was one of the more challenging rhexis, and I'm showing this because at the time, obviously, it was very challenging, but it just shows that I wanted to illustrate that, sometimes the capsulorrhexis may not go smoothly, and so you want to just take your time, and it's a really important part of the case, and it's important to get a good curvilinear capsulorrhexis for the rest of your surgery. Not really important to hydrodissect here. I do it anyway just out of habit, but likely the cortex is liquefied. I am going to speed up the rest of the case here. It looks like there's another 10 minutes remaining on this video. So I haven't watched this video since surgery. So we'll see what we're doing here. The patient's, of course, on the topical anesthetic, and as you can see, the eye can move. Okay, here comes the phaco probe. And my usual technique is a horizontal chop, but we'll see here. Obviously, this is not a regular cataract, and it is more dense than most of the cataracts that I do. So here's horizontal chop. Not really the greatest chop. Here we go. There we go. We see some separation there. Now we're going to cut this, try and cut this nucleus in two, and it looks like we have been able to chop it here. This is double speed. Continue to chop, and finally we're able to raise part of the nucleus here to the iris plane. And this is a large, dense cataract. And so we try to chop it again, but it is rather leathery or rubbery, and it's proving difficult to chop. So we'll keep working at it with our phaco. Once again, we're going to be nice and patient here. We finally get a chop. Still adherent there. You can see how it's just really leathery and doesn't want to break apart. Also, not sure if our phaco, here we go. We're making some progress. I was going to say, not sure if our phaco settings are really helping us here, but we are starting to make some progress. In cases like this, a lot extra time. We're going to be patient. We're not going to get frustrated. We're going to take our time and just work slowly and meticulously to get this cataract out and hopefully restore vision in this patient's eye. Probably could have used stronger, probably could have used more phaco power here for this case. But in any case, we're still making progress. All right, so looks like we got most of the nucleus out, and what's left is just some cortical material, and this should come out fairly readily. We've got my second instrument here protecting the posterior capsule, and we see that there's some cortical material that's adherent to the posterior capsule. We do attempt some capsule polish here, but we're going to leave that material in there. If it's causing a problem, we can consider doing a laser capsulotomy, although I'm not sure that's really going to be an issue. Here comes the intraocular lens. And then we use the IA probe to help position the lens while the eye is under viscoelastic. And then we can see the lens is in good position here, and then we irrigate out the viscoelastic material. There's some remaining nuclear material here. It looks like we want to make sure that we are very diligent and vigilant about removing all of that. We're polishing here under the anterior capsule. You can see the Purkinje reflexes here. The first Purkinje reflex off the cornea, and then the inverted reflex behind it off the back surface of the intraocular lens. These are the Purkinje images here centrally. Okay. So we'll just irrigate out the anterior chamber here, and we're just irrigating the wounds and making sure there's no pieces left in the anterior chamber. We'll make sure the wounds are watertight, and then we'll call it a day. Very good. So I wanted to share this case of a patient with mature cataract, a fibrotic anterior capsule. These cases are not going to have, it's not going to be the nuclear material, the cataract material is not going to be tense. You're most likely not going to get an Argentinian flag sign, but really important just to take your time with these fibrotic capsules. There'll be areas of adhesion. Worst case scenario, you can do you can create a can opener capsulorrhexis. You can also use scissors to start the capsulorrhexis and raise a flap in another part of the eye as well. Thank you for your attention. I hope you find this information useful to you. If you would have handled this differently, please drop a comment on this video and let me know. Thank you very much. Once again, Mohammed Al Mala.